Okay, great. All right. So, welcome to today's session. Today, we are talking about antenatal history taking. We will try to discuss some points in management also regarding antenatal history taking. If you cannot view the screen of the presentation, if you cannot hear my voice, please let me know in the chat box so I can correct it. Because what happens is, when I get the audio back, then I'm not able to make any changes to the audio or the video. So please do let me know. I hope that you can view the screen as well of the presentation, and you can hear me clearly as well. If both the things are okay, let us begin. Can you see the presentation screen too? You should be seeing two screens. In one screen, you will see the presentation, and in the other screen, you should be able to see my face. So, can you see both the screens? Please let me know on the chat box. Yes, okay, great. That's great. All right. Thank you very much. That's really nice to know that today both the things are working fine. If in case the screen or the voice drops, please immediately let me know either on the WhatsApp chat or on the chat box here. Just because the chat box here doesn't mention my name, please don't think that I cannot access these chats. I can definitely access these chats because I'm working for an academy now. So that's the reason why I can't use my own personal account for taking the session. Okay, so that's the reason why you see the CEO or the owner's name over the session. So I have to use the academy's account and then conduct the session. So please don't think that I will not be able to view all these things. Definitely, I can view them. Just let me know whatever the issues are. All right. Okay. Okay, great. All right. So let's begin. Sorry about the delay. Okay. So today we are talking about antenatal history taking. We will be covering most of the components of history taking in the antenatal side or section of obstetrics. Okay, so today's session is focused on antenatal history taking. The reason why I feel that I need to do this is because there are two things, guys. There are two things that you should know. The first thing is that you can have pre-prepared stuff, you can speak from those pre-prepared notes, but the impact of those pre-prepared notes will not be the same as something that you yourself work hard for. Okay, so what do we need to do when we are preparing for the exams? I'm talking to those guys who have a lot of time now. So, maybe you have a month or more. So, what you can do is you can pick up the cases which you have and try to reorganize them or restructure them into a way that, okay, this is what I want to do, this is what I want to ask. And one more thing I want to tell you, please do not think that if I go inside and I try to ask medically relevant stuff, okay, then it is wrong. It is not wrong, because what happens is, suppose today is Friday. Today there is, if for example there is a new scenario which comes on this day, um, there's a new scenario which comes on this day, then okay, there's a new scenario which comes on this day. The next time that it comes, so the concerns of those scenario and the way that scenario comes is quite different. Okay, it's not going to be the same. So for you to have a background knowledge of the topic is going to help you. Okay, it's going to be very useful to you, and this is something that I have encouraged from last year, from day one, that you do need to have some background knowledge. So I have encouraged that. Please take note of that. And today's session, this is what we are going to discuss. We are going to discuss what are those things which are going to be useful for the sake of this particular topic. Now, so I'll just recap quickly. I was saying that today we are going to talk about each question relating to the first trimester, second trimester, and third trimester. So I said that when you are in the exam situation, assess which trimester you are in. If you are in the first one, ask the questions for the first trimester, ask the red flags for the first trimester. You can safely omit second and third trimester and move on to P2 plus P3. If you are in the second trimester, if you have a scenario which talks about a patient coming to you in the second trimester, then you ask 2 to 3 questions relating to first trimester, and then you move on to P2 plus P3. If the patient has come in their third trimester, then ask 2 to 3 questions relating to first and second trimester, and then move on to P2 plus P3. So I said this is how you will shorten your history or elaborate your history based on which trimester the patient is. Okay, so let's move on to the next slides. The coming slides will talk about complaints in each trimester and the red flags to ask in each trimester. So is everybody ready? Shall we move on? Please let me know. Anything you want me to repeat over here, or shall we move on? Okay, great. All right. Coming to first trimester. So first trimester, the basic complaints would be morning sickness, increased urinary frequency, breast tenderness, abnormal discharge. Now, I want to spend some time and talk about abnormal discharge over here. I have noticed that a lot of candidates, they keep saying, have you noticed any discharge? Have you noticed any discharge? When I'm taking a mock or when I'm taking a practice session, I always come across this question that the doctor, the candidate is asking the simulator, have you noticed any discharge? Now, if you ask this sort of a question, the answer to that question will always be, no, doctor, I have not noticed anything. But if you say, have you noticed any unusual or abnormal discharge, you will definitely get the answer. So please add this word abnormal or unusual in your notes. Okay, you have to ask abnormal or unusual, only then you will get the answer, otherwise you will not get the answer. Okay. Okay, so about complaints such as morning sickness, increased urinary frequency, breast tenderness, abnormal discharge, each of these are scenarios on their own. Okay, the presenting complaint is either this or this or this or this. I'm hoping that all of you are aware that if a presenting complaint is this, then you need to do para of that complaint. That is, when did it start? How did it start? How is it now? Do you think it's getting worse? Do you think it's getting better? What is something which makes it worse? What is something that makes it better? And you have anything else associated with this. So for morning sickness, anything else associated goes into red flags. That is, symptoms of dehydration. That's what you want to rule out. When you have a patient with complaints of increased urinary frequency, please decide if it's a physiological increase or it's a pathological increase. In almost 98% of pregnant women, there is an increased urinary frequency due to a physiological process which is known as, can somebody say what is it known as? The physiological process by which there is increased urinary frequency in a lady who is in her first trimester. Yes, anybody? Why does this happen? What is the cause of pressure of gravid uterus? It's in the third trimester, second to third trimester. That's what happens. In the first trimester, the cause is increased plasma volume. Okay, so because of increasing plasma volume, there is a increased frequency of urination during the first few weeks of pregnancy in a priming, especially in a priming. Okay, she'll be very concerned about it. The multiparous ladies will not be that concerned because each pregnancy is different. They may or they may not have gone through the same, so they would know. Okay, so this is the reason why this might happen. So for each of these complaints, there is a physiological reason, there is a pathological reason. When we discuss individual cases, we will go into the details of when to reassure and when to decide about referral. Okay, so what are the red flags in first trimester? Sudden severe headache, burning micturition, bleeding or spotting, And lastly, dehydration symptoms. So for each of these complaints, I have red flags written over here. Now let me talk about those red flags which I've mentioned here. When I say sudden severe headache, what I mean is if you have a patient who presents with a red flag itself, as in I have a sudden severe headache, doctor, and she's in the first trimester of her pregnancy, then you need to rule out if this is because of an existing diagnosis or this is a new diagnosis. So for example, if this patient was already diagnosed with migraine, then you need to find out about that in the history. Now sometimes in some pregnancies, uh, what usually happens is migraine tends to get better because there is a stable and high increase in estrogen, whereas in sometimes, when there is something going on which is very concerning, this patient who had migraine might come back with a more severe form of headache. So you need to keep those things in mind, and this is the reason why I have included this over here. Okay, so if you have a complaint which says patient presented with severe headache and she is only in her first trimester, think about migraine. Please do not rush to decide that this is preeclampsia, because when does preeclampsia start? When do you diagnose someone to have preeclampsia? Very good. To be more honest, it is second trimester. Whenever there is a patient in the second trimester, you can give the diagnosis of sudden severe headache as preeclampsia. Agreed. But in the first trimester, okay, in the first trimester, try not to diagnose preeclampsia because it is very, very rare, or actually, it is not a disease of the first trimester. Okay, so if you have a patient presenting in the first trimester with a sudden severe headache, try to rule out other causes first and then come to preeclampsia. Okay, so this is the reason why I've put this over here. Now, next thing, we are talking about burning maturation. So like I said, if a patient complains of increased urinary frequency, try to find out if it is physiological or it is pathological. Bleeding or spotting. So there is always, sometimes some women may have a risk of spontaneous loss of pregnancies, or basically a loss of pregnancy. So to rule out those things, we are asking about bleeding and spotting. Now, morning sickness. For morning sickness, the red flag you should ask is dehydration symptoms. So what are dehydration symptoms in a lady who is pregnant? Dry skin, dry mouth, increasingly thirsty. Do you feel dizzy? um, what about your urine volume? Has it changed? What happens is there'll be a decreased urinary frequency when a patient is dehydrated. So these are the symptoms, or these are the symptoms of red flags in the first trimester. Okay, so shall we move on to the second trimester? I hope everyone is okay with first trimester complaints. Yes, okay, great, very good. Let's move on. Second trimester. So coming to second trimester, the time when patients start to feel quickening. So that's why fetal movements, nausea and vomiting. Now, morning sickness from the first trimester can continue into the second trimester. So that's the reason why we have nausea and vomiting over here. Abnormal discharge, once again, lethargy, anemia is a major complaint in the second trimester. Shortness of breath. Okay, now this is something which is also a complaint in the second trimester. Why? Because as the uterus starts expanding, patients will feel short of breath, unable to, and they will notice that this happens more during the time that they are taking rest, and they might be very worried, they might be very concerned, and they might come to you. Okay, a second trimester is also the trimester where patient can present with preeclampsia. So that's why here sudden severe headache comes into picture. Along with sudden severe headache, you have some other symptoms like pain in the epigastric region or discomfort in the epigastric region. Um, vision complaints like blurring of vision, seeing floaters or flashes of light. The other complaint related to shortness of breath in the second trimester is, once again, over here you need to rule out if it is due to a physiological cause or if it is due to a pathological cause. So, physiological shortness of breath, how do you differentiate physiological shortness of breath from pathological shortness of breath? In physiological shortness of breath, patient feels breathless, they do not have a history of asthma, atopy or eczema. Okay, these patients, they say that our shortness of breath, it gets better with activity, and it is not constant. We do not experience any symptoms like chest tightness or wheezing or cough or associated with DVT. So you also need to roll out those things, right? So DVT is a complication which can happen in the second or the third trimester of pregnancy. So over here, any calf swelling, any calf pain, and sudden severe pain or sudden severe catch in the chest. Okay, that is a pulmonary embolism being lodged in the chest. So these are the symptoms you can ask for red flags, ruling out red flags. And this could possibly be something which could be a scenario in your exam. We cannot say anything for sure these days, so that's the reason why I'm telling you. The points that I am stressing on, I do hope that you are taking note of those. There might be a physiological cause, there might be a pathological cause. Your duty is to find out which is what in the exam and give reassurance or decide for referral. Okay, so these are the things about second trimester. Moving on to third trimester. Okay, I hope everybody is okay with second trimester. Shall we move on? Okay, great. All right. Coming to third trimester. Once again, in the third trimester, you have complaints of fetal movements, decreased or increased, both can be the complaints, abdominal pain, right upper quadrant pain, and increased frequency of urination. Red flags for these complaints are once again, swelling of hands and feet, blurring of vision, itching, and I have written here vaginal bleeding, but once again, your question would be any abnormal discharge or any abnormal bleeding or spotting which you have noticed. Okay, now let's talk about these things. Okay, now what happens in the third trimester? There are some conditions which make the management for these patients different. Okay, so what are those complaints? When I talk about fetal movements, decreased fetal movements means you have to decide for same day or urgent referral to the specialist. If a patient complains of abdominal pain, sometimes some patients with preeclampsia, they can be symptom free throughout the second trimester. They will present in the third trimester with only the complaint of abdominal pain. So this is the reason why you need to rule out these red flags. So you have to ask associated symptoms of preeclampsia along with after you have done the ODPARA of this complaint. Now, right upper quadrant pain. This is specific for acute fatty liver of pregnancy. Okay, acute fatty liver and pregnancy presents with right upper quadrant pain, polyuria, polydipsia, that is increased urination, increased thirst, and itching. Okay, so these are the things which acute fatty liver of pregnancy presents with, especially in the third trimester. Okay, moving on to polyuria itself being a complaint of the patient, because this can mean any urinary tract infection. So urinary tract infections are common to first, second, and third trimesters both, all three of them. However, treatment in the first trimester and treatment in the third trimester is very different. Okay, so for that you need to refer to your BNF and give the appropriate medication. So this is the reason why polyuria is still here in the third trimester. Okay, so I hope everybody is okay with the history taking questions of all the three trimesters. Just to recap once again, if your patient is if you have a scenario where your patient is in the first trimester, you know the questions that you should ask, you know that I should be doing the ODPARA of these complaints, and these are the red flags that I should be ruling out. And then moving on to P2 plus P3. If you are in the second trimester, brief questionnaire of first trimester, and then move on ODPARA of second trimester, and P2 plus P3, your history taking is done. If you are in the third trimester, few questions about first and second trimester, just one or two questions. Do not spend more time, just one or two questions, and then move on to the Para of third trimester complaints, and then P2 plus P3. So this is how you go about the scenario. Now, but these are the general things that you should know. Okay. Now, moving on. P4. No, actually, I do not have a P4 in my history taking format. I just have P1, P2, and P3. So what I do is I keep history of presenting illness in P1. P2 is past medical history, which includes menstrual, sexual, and obstetric history. And my P3 is basically lifestyle, personal and lifestyle, anything like travel, contact, diet, exercise, all those things, illicit substances, all those things I include in P3 itself. I do not have a separate P4. Okay, so this is my structure is very simple: P1, P2, and P3. Okay.